So today we're really happy to talk with you about high-cost drugs. Our proposed agenda this morning is we're going to touch on a few high points and hopefully create an overall picture of why we want to talk with you about high-cost drugs and why it's important, an important consideration for employee benefit plans. First, we'll talk a little bit about the Health Benefit Trust of Alberta, how we're positioning this conversation relative to our relationships with our customers and the work that we do for you. We'll then drive into a little bit about health plan spend, and we'll talk a little bit about the cost drivers of drug costs and what I like to call the drug mix. We'll move into managing impacts. We'll share a little bit of data with you to explain why things are evolving as they are and the different tools from a data perspective we're using to assess and move our plans forward. We'll then move on to the drug management toolbox, where we'll talk about a few of the things we have in place today and a few of the things we're going to have to think about in the future, and finish off with a discussion around the high-cost drug pool, which is truly unique to HBTA and the services we provide to our customers, and why we think it's an important thing for the management of drug plan costs. So just a little bit of background on where we're coming from this. And I know that as our customers, you're very familiar with the Health Benefit Trust of Alberta and what we do for you and how we work together on a daily basis. But as we move forward with our benefit plan conversations and talking about health and disability and managing employee productivity and absenteeism, we just want to sort of cast the bar a little bit and talk about what we're trying to achieve. And one of the key things, aside from our mission statements and all of those variables you're already aware of, is we want to provide the best class health benefit experience to our customers, their employees, and their families. So when we're talking about benefit plans, we're always talking about, employees and how they help them, and as a component of total compensation, as part of sort of what we deliver to employees to attract and retain them in our organizations. But it's really important from our perspective that we also take a look at how these benefit plans support employee health and keep them at their best as they're helping us achieve our business objectives and move our businesses and our healthcare forward. So it was from this lens that we're kind of beginning to look at drugs from a little bit of a different perspective. So how do we do that? How do we support employee health and keep them healthy and productive at work? Well, from a plan perspective, there's different elements that are involved in that. We offer life insurance. We offer disability benefits in those unfortunate instances where people become ill and have to be away from work to recover from a health event. Accidental death and dismemberment coverage, critical illness coverage, flexible spending accounts, which is a little bit of a different take on managing health in terms that they are available to offer to your employees to claim discretionary expenses that aren't perhaps covered under your defined benefit plans, whether that be through health spending accounts or personal spending accounts. Of course, the dental plan is always a hot topic with all employees. Dental expenses are, of course, continuing to increase, and those plans provide important support for employees and their families. But today we're going to dwell a little bit more on the health plan and how that, from a overarching perspective, is very instrumental in helping your employees stay healthy and productive. So this is a little bit some of the data that we're collecting in terms of the HBTA and the health spend that our plans are spending on health expenditures. The different colors in the graphs, purple is drugs, the teal is for paramedical expenses, and then the bright green is for other expenses we see on the health plan, whether that be for things like foot orthotics or medical equipment, etc. And this graph shows you the increase in cost since 2013 through to 2017 on our health plan spend, which translates for you guys into what your health premiums look like and what expenses are hitting those health premiums. And as you can see, year over year, costs increase. So as costs increase, as your partner in delivering benefits to your employees, we have to analyze those increases and determine ways to not only manage them, but look towards how we're going to manage those types of increases over the long term. And what's interesting about drugs is, although we've seen the year-over-year increase slightly decrease proportionately, for example, we went from an 8% increase in 2014-15 to only a 5.25% increase, and then finally a 3.8% increase last year. An increase is still an increase, and you have to be able to manage those increases in the interest of maintaining the sustainability of the drug plan over the long term. So if we take vision care out of the mix, when you look at your health spend, or your health premium is what it translates to, about 75% of health premium is a result of what we spend on drugs. And the other 25% is a result of all the other expenses, whether that be physio, massage, or anything else that's covered under the health plan. So drug maintains a significant proportion of what we spend on benefits every day. And that's why there is such a focus on trying to manage that component from a sustainability perspective. So why do drugs cost so much? This is a model that was put forth by the Canadian Health Information Network. And they put out a report in 2012 which talked to what the drug spend cost drivers were. And it talks about some fairly typical things that we always talk about when we're talking about benefit spend. It talks about demographics and the different mixes of ages and the different health conditions that come with those ages that drive what people claim from a drug perspective. What's really interesting, I read a stat the other day, or I think it's interesting, that now millennials, or the under 25 to 30, that sort of age band, constitutes the greatest proportion of demographic grouping in our workforce today. So we've almost done a bit of a shift there. But where we have a lot of health conditions and a lot of drug spend is still on the upper edge of our demographic curve in that 45 to 55-year-old band. So although we've got all this younger infusion into the workforce, which traditionally means less spend on drugs because they have a lower proportion of health conditions to manage, the top end of the spend, the 45 to 50, is still continuing to drive the curve and cost our plans significant amounts of money. As a result of those demographics and where the health conditions are sitting, that's where we get what we call our drug mix. And that's where we see what various drugs are being claimed under the drug plan, and in terms driving the cost of those plans. And further up beyond that, some of the experience we're seeing on the disability benefit side as well. So what is the drug mix? Well, the drug mix is what drugs are being claimed on your plan. It's sort of a broad-based assessment. You can divide it into three separate categories. Number one is high volume chronic medications. Number two is high cost specialty drugs. And the third one is acute therapy. I'm going to take some time over the next couple of slides to talk about the first two buckets of drugs. But I'll just quickly mention what I mean by acute therapy because I'm not really going to dwell on that a lot. So when I talk about acute therapy, those are more short-term drug treatments. So antibiotics is a really good example. Pain medications, Tylenol, 3s, those sorts of things. Some opioids fall into that, although that, of course, can progress to chronic use over time. So more of the shorter spectrum treatments fall into that category. And proportionately, they are definitely the smallest subset of drugs that we see on the drug plan. So high volume chronic medications, what do we mean by those? Those are the drugs that are being used to treat common chronic health conditions. Diabetes being probably the most drug-supported condition on the HBTA drug plans. So we'll show you a graph in a moment that shows you that diabetes accounts for the greatest proportion of chronic drug spend across the HBTA program. Why are these drugs costing the plan so much money? Well, because they're being used to treat health conditions that are very common and becoming more and more common, and they are used by a significant proportion of people. So you've got a lot of people using diabetes drugs, you've got a lot of people using drugs for high blood pressure, you've got a lot of people using drugs for cholesterol. And if you times $1 by $10,000, that adds up quickly. So that is where we are getting high volume chronic medication spend on the drug plans. If I look at our most common drugs that are claimed on our plan, I see drugs like Victoza, which is used in the management of diabetes, Dexilant, which is used to manage reflux disease or heartburn, very common. Symbicort, which is used in the treatment of asthma, and Pristiq, which is a newer antidepressant that's on the market. So those are the big high-ticket drugs on the drug plan right now on a per-drug basis. And these are drugs that are used by, and they're sister drugs because there's more than just them, being used by people for common health conditions that are treated over the long term in terms of duration. And not only do we have these conditions that are being treated over the long term and very prevalent, a lot of people have more than one of them. So you might see a patient on drugs to treat diabetes and drugs to treat depression at the same time. So that compounds sort of that relationship. We are seeing more and more multiple conditions and complex conditions coming into this equation, and we are seeing more and more pharmacological support for those. So as you just do the math on that, more drugs over the long term at even a low cost adds up over time. The second bucket of drugs is the high-cost specialty drugs. So this is what we promised you on the title page of the presentation, a presentation around high-cost drugs. I'm afraid we can't just talk about high-cost drugs without talking about the whole equation. So the high-cost specialty drugs, they're in the media all the time. They're drugs that treat some fairly complex health conditions. They're drugs that come to market at price tags of $20,000 per year, $30,000 per year, $60,000 per year, $80,000 per year per patient. And they are becoming more and more common simply because of the complexity of the conditions. We're seeing the conditions that these drugs treat being diagnosed more and more frequently. And we're seeing, of course, people who are a little bit younger being diagnosed earlier, so the long-term projection of treating those conditions, they're being treated over more years than they ever have before. Why are high-cost drugs so expensive? Well, these specialty drugs are a little bit of a different classification from the drugs that are the chronic health condition drugs, the drugs that are just really simply pills, compounded molecules that you take quite easily. High-cost specialty drugs are typically derived from living material, and they are manufactured and handled in a different way than normal everyday drugs. So the manufacturing process is very complex, and as a result, it really can't be replicated. So it's one factory that they make this high-cost drug in, and although a lot of you have probably heard the conversation around subsequent entry biologics or specialty drugs, those drugs aren't an exact replica of the drug they're made to try and relate. So we can't substitute them. So the opportunity to have, drug A come to market and then drug B come to market at a separate price or a lower price isn't quite the same as we've seen in the past with generic drugs on the high volume chronic condition drugs. So some of those drugs that you've probably heard about, my favorite is always Remicade. It is used in a number of conditions, mostly autoimmune based. It has been approved by Health Canada to treat 9 different conditions, and it's considered the last end of therapy or the final resort of therapy for patients who suffer from those conditions. So Remicade is most commonly seen used in Crohn's and ulcerative colitis, very debilitating illnesses. In patients that get to the stage of taking Remicade makes a big difference in their lives, but it is expensive. And it has been on the market for about 20 years. When it came to market and I first started doing this, it cost about $20,000 a year. But because these biologic drugs are made from living material, patients who take these drugs over the long term almost build up a little bit of a tolerance to them over time. So as they are treated over the long term with these drugs, we have to increase their dosage. So as we increase dosage, we increase cost. So what we're seeing now is what used to be $20,000 a year in 1998 has now maybe translated to $60,000 a year in 2018. So these drugs come to market at expensive price tags, and over time the cost for the patient does increase because we have to manage their dosage over the longer term, and we're seeing more and more people using these types of drugs. And as a result, our high-cost drug specialty spend continues to increase. I saw a stat the other day that indicated that specialty drug spend has increased 71% since 2012. Up on the slide is also some more of the common specialty drugs that we're seeing on the HBTA drug plan. So Xolair, which is used in the management of asthma, Humira, which is used along the same lines as Remicade and Enbrel in the arthritis, Crohn's, ulcerative colitis, autoimmune arena. Gilenya, being used to manage multiple sclerosis. So we're seeing a lot more use of multiple sclerosis drugs across our drug plans, and it's something we have to watch for. And finally, Epclusa. Epclusa is a little bit different. It is one of the hepatitis C drugs that has come to market over the last couple of years. What's different about Epclusa and Harvoni before it is that it is a treatment that is more definitive. Once you take Epclusa for a certain period of time, your hepatitis C serology almost drops to zero, and it quote-unquote delivers almost a cure. So on Epclusa, we're not seeing the long-term use over time. We're seeing like 26 to 28 weeks of therapy, but that's coming in at between $80 and $100,000 per patient. So we've got our high-volume chronic condition drugs, and we've got our high-cost specialty drugs, and that's what's driving drug plans today. So how do we manage that? Well, there's a lot of people trying to figure that out right now, and I don't think there's a one-size-fits-all answer. I'm sure we would all love a silver bullet, but nobody's found it yet. There's several things we have to look at when we're managing the impact of these drugs and managing costs and trying to keep premiums and coverage affordable for employees and employees within our organizations. There's several things we balance when we're thinking about that. You know, one of the key things we need to think about is our employees and the outcomes they're getting from those drugs and how we're best supporting their health. So a lot of people, you know, in various sectors or various segments might say, well, why are we even covering those high-cost drugs? Well, because it's important to support our people and keep them healthy and productive. And if we think about it, even a $60,000 Remicade and how that compares to a disability claim and what that costs an organization, I mean, there's offsets there, and keeping people productive and at work and not on disability does have value in and of itself from both a organization perspective and a cost management perspective. So we have to consider all of those variables when we're looking at drug plans and managing impacts across the board. We have to look at plan design and plan management features, and we have quite a toolbox of those that I'll go into in a moment to talk about what we're doing today to try and help manage those costs on your behalf. We have to look at what's going on in the environment. So different things that are going on at different levels of healthcare that help manage costs. So for example, pricing initiatives out across Canada. There was an initiative introduced April 1st where the body of the federal government negotiated a decrease on the price of 70 of the top generic drugs in the country, across the country, bringing those costs down, which then means that those lower costs are what are being claimed against our drug plan. That saves us money. So we have to be aware of some of those factors and incorporate them into what we do every day. We have to look at our underwriting, and that's a key thing that we talk to all of our customers about. Every year we look at premium rates, and we have to manage those rates accordingly. So we have to look at our underwriting and what drugs are costing us today and what we think will cost us in the future, and how that impacts underwriting go forward. But a key thing, and I've kind of put that as the center of all of the impact considerations, is evidence-based decision making. So 20 years ago when I first started doing this, you know, there was a lot of talk about, you know, the drugs, and our biggest issue was, you know, this pill costs us $3. What does that mean? 20 years later, we're dealing with $80,000 per patient per drug per year. It's a different equation. And what's important in terms of how we look at the equation is data. So we are actively working more and more to collect more and more data in terms of what's going on in your drug plan, what things are costing us, and how we take that information to work with you to manage those costs over the longer term. I like to call it, let the data tell the story. This is our top 10 health conditions on the HBTA drug plan by drug plan spend. So I'll just quickly, because I know it's really small, read out the conditions. So we look at Crohn's and ulcerative colitis, which is primarily driven by claims for Remicade and Humira. Number 2 is diabetes. Number 3, cardiovascular disease. Number 4, depression. Number 5, asthma. Number 6, rheumatoid arthritis. Number 7, multiple sclerosis. Number 8, attention deficit hyperactivity disorder. Number 9 is reflux. And finally 10, pain and narcotics. Those 10 groupings of health conditions account for 50% of HBTA drug plan spend. So if you think about all the conditions that are out there and all of the drugs that are out there, I think that tells us a significant story when you can boil it down to 10 key conditions influencing half the spend or half the premium dollars that an organization is paying. If you take a closer look at the graph, the bars show the spend in that fiscal period, whether it be 2013, 14, 14, 15, 15, 16, or 16, 17. And then the numbers within the bars tell you the number of unique patients that are claiming that drug therapy. So for example, the first bar on the left for 2013-2014 is the purple bar for Crohn's and ulcerative colitis. And at that time, there was 1,103 patients claiming treatment for that condition. If you fast forward over to 2016-2017, you can see that the unique number of patients on that bar has increased to 1,293. So by 200 or so patients, almost 300 patients. So as you add patients and you add the different mix of drugs, that drives your cost, and you can see that trend line go up over the years, health condition by health condition. Diabetes is our most costly chronic high volume condition, and we're seeing up to 9,500 patients for that in 2016-2017. Cardiovascular disease and high cholesterol coming in at, for cardiovascular disease, 23,000 patients. So that's where you get the higher number of people at the lower cost of drug, but still making an impact. And finally, for the depression drugs at number 4, we're looking at 23,700 patients last year. So that's the math. The number of people, the cost of the therapy translates into driving your spend. This is just another indicator we use to look at what's driving spend. This is top 10 drugs on the plan by spend, not health condition. And as you can see, a lot of those drugs that I talked about in the earlier slides are depicted here. Remicade, Humira, both used for Crohn's and ulcerative colitis. We've got Botox coming in at number 3, and I will caution you right now, it's not the cosmetic Botox. It is the Botox used to manage migraines and muscle spasms. Significant use out in the population for those indications for Botox. Xolair for asthma, another asthma drug at Symbicort, Enbrel, Victoza, Gilenya, Neulasta, and Mirena. And out of these top 10 drugs, 7 of them are considered high-cost specialty. So you've got, again, your equation, the trends just play over and over and over again. Another thing we look at is whose health are we supporting? So benefit, it's very important that health plans support, the employee and their families, because family is a big component of how employees are healthy and productive at work. As we look at the data, we can see that the vast majority of spend, or the vast majority of premium dollars, is going to supporting the health of employees across our HBTA program. So 67% of drug spend in the 2016-2017 year was for employees, and with 22 to spouse and 11 for dependents. Have to keep in mind as well, the concept of coordination of benefits does come into play there. If a spouse has a plan through another employer, that's where the vast majority of their drug spend is being claimed. But still, it's good to see that our plans are supporting our employees as much as they can. We've also broken down the health conditions by employee, spouse, dependent. And the trends really aren't that much different than what we saw in the prior graph in terms of the conditions we're managing, Crohn's, diabetes, et cetera, et cetera. But again, showcasing that these premium dollars are going to support employee health across all of those conditions. So over time, as cost has evolved, as health conditions have evolved, as spend has evolved, we've had to evolve what I call our drug management toolbox to try and address what's going on out there to keep plans affordable and sustainable, yet still managing employee health and keeping them healthy and productive at work. So across the bottom of this little graphic, this is kind of the saying I like to talk to when I'm talking about drug plan spend and managing drug plan spend. It's looking at the right drug for the right condition at the right time, at the right place in therapy to create the right outcomes. So drug plan management shouldn't be about taking things away. It should be about managing to make sure that the employees receive the best therapy they can at the best point in their condition. And we've got a lot of features in place that help us manage that. Many of you, I hope, are familiar, and you may not be familiar if you've never had to go through the process, but all of our drug programs have what we call a special authorization component to it. So for a predefined list of drugs, mostly high-cost specialty, including Enbrel and Humira and Remicade, and a lot of those drugs that I talked about previously are subject to a special authorization process administered through our drug plan vendor, Alberta Blue Cross, where when a patient needs one of these high-cost drugs, their physician completes some paperwork for them and submits it to Blue Cross, and it's reviewed by clinical pharmacists to ensure that the patient is at that appropriate place in therapy to make the best use of that drug at that time. So they really are checking to see that anything prior, because as you know, as being in healthcare, there's different levels of treatment for different conditions, and that they've reached the point in the condition where this is the best and probably the last resort in many of these cases to help manage their condition. So that's a process that's in place today, has been in place as long as I've been doing this, and is very effective and managed quite seamlessly between Blue Cross and the physician to support the employee as best that we can. Another tool we have out there is step therapy. It's applied right at the pharmacy counter, but what it does, and here's the most common example, is in the world of diabetes. There are many types of treatment for type 2 diabetes. The first step in most cases for type 2 diabetes is a drug by the name of metformin. And then you step up to drugs like Victoza and other drugs that are out there. What step therapy does is it checks the patient's record when a claim comes in for, let's say, Victoza, which is a higher level of therapy, to make sure that the metformin was tried before the Victoza is paid for under the plan. It's all done at the point of adjudication or when you present the drug card, and it's a very quick process, but again, it's just a quick check to make sure that people are accessing the first step before they jump to step 5 in the drug therapy world. Another critical piece to managing the drug plan is about the drug review process. Drugs come to market every day. And our contracts and our plan designs through the HBTA outline what drugs, or kind of give a criteria for what's covered under the plans, and every drug that is reviewed or comes to market is reviewed against that criteria and is only added to the plans if it meets that criteria. So the HBTA has a very broad definition of what is covered under the plans. It gives very excellent comprehensive coverage for employees, but it's a check and balance in place administered by Blue Cross just to make sure that the drugs coming onto the plan are those that are supposed to be there and provide the best support for employee health. Managing pricing is an important piece. So many programs under the HBTA have what we call least cost alternative or generic pricing, which is an advantage to both the plan and employee if they claim the generic rather than the brand name. So that is in place and administered for most of our programs across the board, and it does generate savings. Our statistics show our generic saturation is about 60%, which is really good across the industry. So we've done a really good job of promoting generic and using that to support employee health across the board. Cost share is another important piece from a drug management perspective. So an 80% coverage level where both the employer plan and the employee has almost a stake in the cost of that prescription. It seems to help incent proactive behavior on behalf of the employee, because they too are sharing in that decision-making process in terms of what they're claiming under the plan. So that's an important tool. Different plan design features like smoking cessation, maximums, those sorts of things can come into play as well. And finally, a little bit of a new thing that we have that's kind of come into the market in the last 3 to 4 years is called product list agreements. These are agreements that are negotiated by our provider, Alberta Blue Cross, on behalf, and they negotiate directly with the drug manufacturer on high-cost specialty drugs to try and bring down the cost of what the drug plan pays for those drugs. And when we get rebates back on that, we actually share that out amongst the HBTA program. So that's a good thing that's negotiated by by our provider on our behalf and work they do for us. They're becoming very common across the industry. Every benefits provider has them, and it's really helped in the industry to try and bring some of the cost of those specialty drugs to a more manageable. Finally, there's one advantage offered by the HBTA that I haven't seen anywhere else in the industry, and that's what we call the high-cost drug pool. This is an initiative that is unique to HBTA and occurs as part of the annual renewal process. So you've got drug spend going on all year long. Once a year, we do a renewal process where HBTA goes in and assesses what premium rates are required to sustain the drug plan over the next 12 months. When they do that, they actually take what we call the plan's experience or the plan's claims data, and they take a look at that data and they use that to set the premium rates. But as part of that process, they also take a look at high-cost drug claims. And depending on the size of the employer, where there is an individual who claims for a drug over a year that either exceed $5,000 per individual or $25,000 per individual, only the first amount is taken into account for the experience for your renewal, so the first $5,000 or the first $25,000, and any amounts over that in that year are then credited to what we call the high-cost drug pool. So those amounts over the 5 or the 25 are not taken into account for calculating your premium rates, which is a great advantage for all plans, because they are not then, having to absorb that into the premium rates across the entire population. So as an example, if employee A claimed $30,000 for drug X last year, so if you're less than 1,000 lives, 5,000 of that goes into your experience. The rest of it goes into the high-cost drug pool. The high-cost drug pool was established in 2012 through surplus. And where there is an individual who claims for a drug over a year that either exceed $5,000 per individual or $25,000 per individual, only the first amount is taken into account for the experience for your renewal, so the first $5,000 or the first $25,000, and any amounts over that in that year are then credited to what we call the high-cost drug pool. So those amounts over the 5 or the 25 are not taken into account for calculating your premium rates, which is a great advantage for all plans, because they are not then, having to absorb that into the premium rates across the entire population. So as an example, if employee A claimed $30,000 for drug X last year, so if you're less than 1,000 lives, 5,000 of that goes into your experience. The rest of it goes into the high-cost drug pool. The high-cost drug pool was established in 2012 through surplus and is refunded each and every year, is reset each and every year. So those claims go over to the pool. Your experience only accounts for the first 5,000, and your premium rates reflect that accordingly. So as we look to the future, what do we need to think about? Well, there's several things. We have to think about all of those things we just talked about right now, but we also have to move the dial a little, because there are some looming challenges in terms of drug costs that we have to take into consideration. With the federal budget that was announced at the end of February of this year, the federal government announced again that they were going to start looking at national pharmacare. What that means across the country and what that means for Alberta and what that means for employer plans is certainly unknown. We've certainly heard that conversation before in the benefits world, but it's something we have to think about. Something could come out of that whole review process that could impact drug plan pricing across the board, the price of generics, the price of high-cost drugs, whatever it could be. So that's something we have to continue to think about and take into consideration as we look down the road in terms of managing our drug plans. What's in the drug pipeline? So the drug pipeline is what we talk about when we're talking about new drugs that are coming to market. Sources indicate that the drug pipeline is full. It's been pretty slow the last couple of years. There haven't been a lot of new blockbusters coming to market, but sources indicate that the pipeline is full, and it's full of biologic drugs. So that goes back to that whole conversation about the high-cost specialty products. The other consideration within this drug pipeline is when I talked about Remicade, for example, I talked about $80,000 per patient per year. We understand there is a proportion of drugs in the pipeline right now which we are referring to as everyday biologics. So they're biologics coming to market, not at $80,000 per patient per year, which is where we're at with some of them, but more like $10,000 to $15,000 per year. And there's a couple of note, one being suggested for migraines and another being suggested for pain management. And initial indications suggest they could be used by quite a broad base of our population. So you could be getting a combination of the high-cost specialty drug and the chronic condition patient count coming together. And that could create significant pressure on drug plans. So that's something we're watching very carefully as well. The complexity of conditions, again, they keep evolving, and people are being diagnosed with multiple conditions at the same time, so we have to continue to watch that. Just a note, I was reading some stuff from other provinces, and in Alberta, because we have the Alberta Cancer Program, the government takes on a lot of the costs for the cancer drugs in the province of Alberta today. We're very fortunate in that regard. Other provinces aren't so fortunate, but those provinces are actually dealing with, and plan sponsors in those employers in those provinces are dealing with a lot of cancer drugs coming to market that aren't being managed through similar provincial programs in other provinces. So we are getting some offset from that in Alberta because cancer care does take care of some of that spend. But there's a lot of the complexity of the cancer and the oncology world will continue to expand and flourish, and there is, always a risk that some of that can spill over to the private drug plan where the cancer board doesn't pick things up. Again, we have to keep looking at pricing and different federal and provincial initiatives to bring drug pricing down and maximize those savings as much as possible. We have to keep, again, looking at the environment beyond the government, beyond the pricing, various other initiatives and programs going on, migration perhaps from, into more at-home care. We've got the outpatient programs, but if those shift, so we always have to think about what's shifting in the health environment and how that filters down to us. And finally, evolving population health. So, you get kind of hopeful when you hear there's lots of millennials out there, and hopefully that's reducing your risk spread on your employee plan, because, as more younger people with less health conditions come into the workforce, you would hope that by averaging it out, you wouldn't feel the spend, but we've still got a lot of spend on the 45 to 55-year-old age bracket and higher than that as people move through those age bands. And the diabetes, the high blood pressure, the cholesterol, the depression, those conditions are continuing to increase, particularly as our worlds become more complex. We have to balance things, but that's coming out in our health conditions. So as that continues to evolve, we're going to have to try and manage that across the drug plan, and beyond that, the disability and life programs as well. So that, it's not just a drug conversation, because anything that spills out of that can hit the disability plans, and that's another consideration we have to think about. It's always an evolving field of discussion. It's not a silver bullet. There's not a lot of one answers for a lot of these equations, but there are things that have to be looked at over the long term, things that have to be looked at within consideration and consultation of each other. And we, as the HBTA, will continue to monitor what's going on, continue to bring you information with the ultimate goal of providing the best health benefit experience for you as our customer and your employees and their families, and that everyone sees the value of participating in our program. If anyone has any questions, we're certainly available here to the HBTA to answer your questions at any time as well. So if you have any questions, please don't hesitate to email our HBTA mailbox, and we'll be happy to get back to you as soon as we can.